So the first case, a 57-year-old male who is fit and well. He's been working at a private healthcare clinic until quite recently. And he'd come to hospital reporting breathlessness, swelling, and a rash that had been affecting his upper limbs. Breathlessness had started about 10 days prior to presenting. Initially, he'd just noticed it when he was climbing stairs. He was having difficulty having to stop halfway up. And in the days prior to presenting to hospital, he was actually having to stop while walking on the flat. So he'd get across 2 blocks on the street, and then he'd have to stop and take a seat. 48 hours before coming in, he'd also become extremely swollen. So this was a patient who'd come in wearing basically Doc Martens and black skinny jeans, and you could see that those skinny jeans were kind of tearing at the seams almost, because his legs were quite swollen. And his arms, which were also had quite a lot of tattoos on them, they too, you could see that he was really kind of pushing the shirt that he was wearing, and it was very tight fitting. And he'd also mentioned that he'd had this dermatological condition called nodular prurigo for a couple of years, that he was sort of putting on some steroid creams from intermittently, but that in the past 2 months, he'd noticed these spontaneous bruises appearing in his limbs, and he wasn't really sure what they were. They weren't painful. They didn't blanch when he pressed on them. So those were his 3 main complaints. In terms of his past medical history, there was this nodular prurigo that had been managed with a dermatologist for the past 12 to 24 months. He had asthma. He was diagnosed with hypertension, and his admissions to hospital included an admission in 2019. I'm not sure he actually stayed the night here. I think he was managed in the ED, but he was diagnosed with a cavitating pneumonia and investigated as an outpatient with a respiratory team. They didn't find any evidence of TB, and it was ultimately attributed to a sort of post-flu severe bacterial pneumonia. He'd then come into the ED a few times in 2020, and again in 2021. And in 2020, he interestingly presented with swelling and shortness of breath again. They'd noted that his albumin was a bit low. And he mentioned that he drunk beer daily, so he was ultimately discharged with a course of frusemide, and for the GP to investigate the low albumin in the liver. And then in 2021, he presented with a headache after receiving the AstraZeneca vaccine, and his blood pressure was above 200 systolic over his, sort of 12 hours or so that it was being monitored in the ED. So that on that occasion, he was sent home with analgesia and started on amlodipine. And by the time he presented to us in December 2021, he was on 10 mg of amlodipine once a day, salbutamol, and this a cream for his nodular prurigo. He didn't smoke, non-smoker. He was a daily beer drinker. He lived with his wife. He denied any intravenous drug use, no recreational drug intake. And like I said, he'd been recently made unemployed from this private clinic. The pandemic apparently has complicated things where he was working. On examination, so as I said, he was extremely edematous from the foot of the bed. His jeans were, very stretched at the seams. You could see the stitching. He had this non-blanching kind of bruise-like patch or macules on his upper limbs, and you could differentiate those to us. You'd be pointing at these nodules that looked excoriated, and that was his nodular prurigo that he applied cream to. And these other bruises were sort of alongside his tattoos and looked a bit unusual. The edema was pitting all the way up to his shoulder and his thighs. He had a very soft systolic murmur and was running quite quickly, 100 beats per minute. Blood pressure was 171/74, and that was roughly what he averaged at throughout the admission. He wasn't pyrexic. He didn't look short of breath at rest. He was able to speak normally. He didn't have an increased work of breathing, and his SATs were, above 95. But I guess a respirate of 18 in somebody that young is a bit unusual. His abdomen was distended. It was non-tender. I couldn't palpate any enlarged organs, and there was some shifting dullness. His chest was quiet in both bases and dull to percussion. So the ECG showed that he was in sinus rhythm. There weren't any sort of ischemic changes or sign of, there were no abnormal Q waves or T wave inversions. His axis was normal, and it was just showing that he was going at roughly 100 beats per minute. and his chest x-ray, and because he'd been to hospital for that pneumonia in the past, he'd been followed up and had some interval x-rays. So on the left is an x-ray from 2019 after he'd completed his course of treatment. And you can see here that nice clean x-ray. And when he came in December, he'd had these bilateral pleural effusions on the left-hand side, in particular, was bad, and it had actually extending, and you can see the oblique fissure filled with fluid in the left lung. Both costophrenic angles have disappeared. And you can see that I mentioned that he was in 2020, so in the midst of, I think, wave 1 of the pandemic, or that he'd also had pleural effusions on that admission. This perhaps had been something that had been ongoing for at least a year.
And the X-ray on the first one, PA 2019,
Yep.
Was that pre or post cavitating pneumonia you mentioned?
That was after the cavitating pneumonia. So I think he'd had some x-ray, that would have been the interval x-ray after the previous x-rays. And I don't have any, I didn't download the x-rays of the cavitating pneumonia actually.
Okay. Any thoughts from anybody? Should we ask the audience to, or do you want to go through some questions?
Let me just, I don't know what comes next actually.
Okay.
I guess we could ask the audience what, because I've got I'm happy to show everyone the pathology that comes when you see somebody in the ED,
Mm-hmm.
or we can ask now. So I guess I'll ask now, and if anyone has anything to add.
This is where everyone sits there quietly, not wanting to. Can someone unmute and ask a question? Or tell us what they think the differential diagnosis is?
Did anybody dipstick the urine in ED?
So they did, and I guess we'll come to that, and that's the question I was going to ask next. So I guess I'll show the blood tests, but the urine investigations were requested in the ED, and we can come to those in the slide after the next one. But I'm glad you asked that.
Mm-hmm.
So just the basic pathology that you get presented with when someone's in the ED, and I've coloured these the same way Cerner colours them. And he had an AKI. He had an elevated neutrophil count, and he had a low albumin of 23. And at this point, his clotting was normal, his SARS swab was negative, and the CRP was 0.4. So summarizing, this is some 57-year-old daily beer drinker with asthma and hypertension who came in with shortness of breath, generalized edema, and low albumin. And the question someone asked was urinalysis is what they wanted to see. So I can show you the urinalysis. Is there anything else anybody would like to add at this point?
Katie does good herself by saying it's not a lung problem, even though the lungs are full of fluid. Oh, she has put urine, PCR, and MCNS.
Sorry, can I just check? Was it when he was earlier in the for the hypertension? What was he started on for that?
I think it was amlodipine that he was sent home on, and that's what I think he'd just been titrated to 10 mg when he arrived to us.
New medications.
Sorry?
No other new medications?
No.
Cool,
Had he,
thank you.
because of the cavitating pneumonia, had he had an HIV test at any point before?
HIV negative.
Yeah.
Any other tests that anybody else wants? Lipids? I don't think have we got lipids, Rafael? Someone's asked for lipids.
Yeah, no, that's a good, yeah. So I don't know if I have, I think I might have lipids, but the lipids weren't actually deranged. I did request those and they came back and they were all within there was no hypertriglyceridemia or hypercholesterolemia.
Okay, and Katie's asked VTE question mark.
He didn't, as calves weren't tender to palpation, you know, he just had this pitting edema. He wasn't having any pleuritic chest pain. And in terms of thrombosis in other places like the dural venous sinus, you know, he'd had a CT head when he presented earlier after the Chaddox vaccine, and that was clear. And he wasn't having any headache, nausea, or vomiting when I saw him. No blurring of his vision, no changes to no symptoms of a pressure headache. I guess what I'm trying to say.
Okay,
that's a really good important thing to to ask right there and then.
Okay, an important question from Doris is about the old creatinine. Is this an acute or a chronic creatinine problem?
So the baseline creatinine that he'd had going back to 2019 and just looking at his results, he was quite steady between 80 and 100. So this is an increase by an additional 50% on his baseline, and his urea was 15 and the baseline was 5. So this is very much a kind of an acute on chronic picture. No, sorry, an acute, not on chronic.
Did we have eosinophils done? Sorry.
Sorry?
Raised. What eosinophils done? Oh, sorry, they would have been done, but do we have a value? Were they raised?
No, the eosinophils were done, and I've not included the actual number here because they were low. They weren't markedly elevated. The only time eosinophils came up in his admission, looking back at the part, was when they took biopsies of his skin lesions 2 years prior to this as part of the workup of dermatology, and they had some eosinophils there, and that was ultimately diagnosed as a kind of an allergic rash and with nodules, and so it's called nodular prurigo. That's all I could gather from those notes. He didn't have an eosinophilia, yeah.
Have you got an ESR?
Sorry? The ESR, from my recollection, the ESR very mildly elevated. Okay, so the urinalysis, and just because someone asked this early on, I suspect they were perhaps unsurprised, showed 4+ of protein, 4+ of blood, and the albumin creatinine ratio and protein creatinine ratios were all within the nephrotic range, so really markedly elevated. We requested an ultrasound scan, which was done the following morning, which kind of confirmed that he had ascites. They incidentally reported pleural effusions, but they otherwise showed normally sized kidneys with no focal lesions and no structural abnormalities. So based on everything we've just discussed, what are the following diagnoses are we suspecting? And I guess Prof. Mirren can bring up the,
Does that work?
Yeah,
yes,
you
it
can
has.
probably
Okay.
ask for one. Say one, but just put down whichever one you think is the best. And I guess I'll tell you what I think is the best, but
I see. I think I might be able in future, I'll try to offer more than one option. Yeah.
That's all right.
Okay, so come on everybody, we've got 29 on and 12 of you.
We should be able to get 2 answers. Sure.
Okay. And Katie's using the chat for some reason. Katie, just choose one of the options. Okay, I'm going to show you what people think.
Okay.
Yes, all right.
Great. About 50-50 between nephrotic and glomneph.
Mm-hmm. Okay, I'll stop sharing. Okay.
So to be honest, if you put any of the top 3, I think the answer, the best answer would be glomerular nephritis, because he's presented with what looks as very frankly nephrotic, but over the past 2 years he has exhibited signs of nephritic, but we don't have any of the urinalysis to go with it. We know he was very hypertensive. We know he presented in the past with edema. It's likely that there would have been blood in the urine and protein in the urine had it been looked at in 2020, for example. And I remember when I was seeing the patient, in my mind, I didn't know whether to call it. I think I ended up going with a nephritic syndrome, a protein losing nephritic syndrome. And I've got a few slides just going ahead to kind of perhaps explain the rationale. So all of these 3 are primarily diseases of the glomeruli. So this is an electron micrograph of just the vessels, vascular cast of 2 glomeruli. So you can see the tiny capillaries and the afferent and efferent arterioles emanating from them. And just to go through the definitions for anyone that doesn't know, I'm not sure if we have any medical students on the talk today, but any proteinuria greater than 3 grams over 24 hours, which you can estimate effectively with the protein creatinine ratio and albumin creatinine ratios, edema and low albumin, is nephrotic syndrome, and he meets that criteria. Having blood in the urine, usually with an element of hypertension, would suggest nephritic syndrome. So the patient technically meets both criteria. And diseases of the glomeruli, the reason you can get blood in the urine is because it's ultimately the perturbation of this, the microvasculature and this filtration organ leads to the spillage of protein and or whole cells into the renal tubules. And had we sent off any urinary microscopy, which I'm sad to say I didn't, because I completely forgot at that moment that this was something that would have been useful perhaps, we probably would have seen some red cell casts or some white cell casts. And the reason for that, you can see this image taken from a website of red cells just kind of collecting in the duct and eventually being presumably passing down into the renal pelvis, bladder, and then our collection tube. So now that we've got the diagnosis of what the syndrome is, what would the next investigative steps be? And some of these have already actually been suggested. What would be the barrage of tests that we could request now in the ED that would save the acute medics and the nephrologists perhaps time in subsequent follow-ups? What pathologies would we like to kind of punt for as a diagnosis here?
Katie wants to send it to the renal assessment unit. but she's also has previously suggested a biopsy for nephritis.
Yeah, definitely we need a biopsy. But I guess before the biopsy, what we could do as the acute medical team, I guess my thought process was they'll need a biopsy and I need to discuss them with the renal team. So I'm not going to start any acute management until.
Okay, here we go. So Ben has said full autoimmune screen,
yeah.
And Joe and 8 North have expanded it to anchor, NA protein, C3C4, MPO, anti-GBM.
Yeah.
They've listed a load of antibodies. It'd be quite nice to not just say full renal screen, but to do the ones we want, because part of the problem is we do tests that are not indicated as well, and then we sometimes get false positives. So yes, thank you, Joe, for the specificity.
So yeah, the idea is that we screen for all the possible causes of glomerular pathology. And the nephritic and nephrotic syndrome are just two ends of a single spectrum that are caused and manifest as a result of a variety of different pathologies. And some of these pathologies are very easy to test for. So we can look for diabetes with the HbA1c, you can screen for amyloidosis, obviously with the serum light chains and protein electrophoresis. Some of these pathologies are caused by the deposition of antibodies, and you can test for those antibodies. So if he hadn't had a recent sore throat, but you could chuck in an anti-SLO if he had any evidence of sort of pharyngitis in the months preceding the presentation. The autoimmune screen again fits in with screening for SLE, IgA nephropathy, and the vasculitis disease. And so there's a bunch of non-invasive tests that we can order, knowing that he's going to have a biopsy, but that without the non-invasive, sometimes the non-invasive tests give an answer that really help the interpretation of the biopsy results. And in terms of what causes these different diseases, is that the glomerulus is made up of a variety of different structures. And it's quite odd how damage to the glomerulus can manifest quite differently in terms of predominantly blood or predominantly protein and edema. And the sort of pathological reasoning behind that, it depends on what cell and what structures are completely impaired. So nephrotic syndrome is broadly damage to podocytes. So the glomerulus is split up contains 3 different layers of filtration. So the afferent arteriole brings in blood at relatively high pressure that then passes into these capillary loops. That blood is then filtered through the fenestrated endothelium, which is the first filter. Then it has to get through the glomerular basement membrane, which is quite unusual because it's a membrane that's shared with the endothelium of the capillary, these mesangial cells that kind of make up the core of the glomerulus, holding it together, and also the epithelium of Bowens Capsule. So it's a single basement membrane for 3 different cell types in one organ. So that's an important filter. And then the epithelium of Bowens Capsule contains these podocytes that largely just sort of float within the primitive urine and remain attached to these capillaries with their end feet processes. And these interdigitating fingers provide another kind of mesh that electrolytes and fluid are filtered through. And these 3 layers in health quite successfully sequester proteins that are large, like albumin, and blood cells within capillaries. But electrolytes glucose, urea, water spills freely to form the primitive urine, and the composition of the fluid in Bowens capsule is, in terms of electrolytes and water content, is identical to that plasma, aside from it lacks the proteins. If you damage podocytes, either because your body's decided that the podocytes are an untoward cell and you lose tolerance to them and produce antibodies to any component of them, you then manifest with nephrotic syndrome. If you're born with a mutation in a gene that's highly expressed and necessary for podocytes to remain attached to that basement membrane, you'll probably develop nephrotic syndrome in the first 10 years of your life. Alternatively, if you develop antibodies to other components, so either the vessels themselves or the mesangial cells, these antibodies deposit over time, you'll manifest with more of a nephritic presentation. And these antibodies can either be directed against a component of the glomerulus, or it could be just complexes that form serendipitously in the context of a long-term viral infection like a hepatitis or HIV, or an immune complex disorder like lupus. And these complexes just have a habit of depositing in small vessels. And that's why things like lupus and chronic viral infections can also manifest in either the nephritic or the nephrotic syndrome. So it all depends on where these things deposit. And so I teach medical students about Hep B, and I remember being a medical student and being really puzzled as to why none of these pathologies, or perhaps I wasn't in the lecture when they were presented, but I'd never heard of nephrotic or nephritic until I was in, say, 4th year of med school. And that was after an immunology BSc and, the preclinical curriculum. We did lots of immunology. We all had to learn about complement, which everyone hates, frankly, even immunologists, but I hadn't come across these pathologies. And Hep B, I always wondered why Hep B can manifest with these weird sort of vasculitic issues. And so I always try and make an effort of linking this to teaching of Hep B. And I feel like it gives a good prototype of how the glomerulus can be so impaired. So Hep B infects the liver, and someone who's chronically infected with Hep B will produce, infectious viral particles that can transmit from one to another, via blood transfusions, IVD needle sharing. But rather than just producing infectious particles, it produces log-fold greater numbers of completely seemingly useless filaments and spheres. And so this is because the hepatitis surface antigen is produced in great excess, so the envelope protein, to every other gene in its genome. And that excess protein ends up just budding away from liver cells, and you end up in the circulation with just bucket loads of these filaments and spheres, and antibodies develop against these things. They form complexes and they deposit in the kidney. And an MRCP question would at least would come up in question banks, expecting us to make this one. I've not sat part 2. And the reason that these complexes deposit in a particular region of the glomerulus, and it's just between the basement membrane and the podocytes. And if we look at the histology that we all generally didn't really enjoy learning about at medical school, generally the pink is proteins and the blue is nuclei. You can just about make out Bowens capsule in a normal healthy glomerulus here, and a few spaces that would be the capillaries. So this is a healthy glomerulus. Somebody who's chronically infected with Hep B who develops a nephrotic syndrome, you can see there's a big accumulation of pink stuff just where the basement membrane would be. And that's why sort of chronic viral infections can, for example, manifest in very specific glomerular diseases. And if you were to then stain for immunoglobulin G, you can see that lots of that immunoglobulin is all in this kind of subpodocyte suprabasement membrane region. So the immunological workup for this chap was actually quite unremarkable. So immunoglobulins themselves are quite useful things sent off. He just had a slightly elevated IgA, didn't have any evidence of prior diabetes. The vasculitis screen that I sent off was not a complete vasculitis screen, but there was no evidence of any complement deficiency or consumption. There were nothing positive on the ANA and ANCA screens. The myeloma screen was unremarkable. So he had slightly elevated chains perhaps, but the ratio between the two was 1. The electrophoresis just confirmed that he had low albumin, which we already knew. And the viral screen, which is important to send off alongside the autoimmune screen, was all negative. And phospholipase A2 is the most common, is the most common driver of nephrotic syndrome in presenting in adulthood. And I hadn't sent this off in the ED, but the nephrologist sent it off later, and that was negative as well. So at that point, we very quickly post-take to the patient with Dr. Milanes. And before starting anything, I then called the renal registrar because we were, quite worried about this previously fully independent, young, healthy male presenting with potentially a life-changing diagnosis, and I didn't want to get anything wrong. And in particular, I was concerned about sort of VT prophylaxis, whether not to give furosemide, etc. So they advised to admit the patient for an inpatient biopsy, and there were no beds at the Hammersmith, unfortunately. And this was around COVID, the most recent wave, so that's probably why. And so that plan eventually changed to an outpatient biopsy. So which of the following is not a commonly cited complication of nephrotic proteinuria?
Now, can I check? Can there be more than one answer, or just want one answer?
Go ahead, sorry.
Do you want more than one answer? I've set it up now, so.
Oh no, just one answer for this one.
Just one answer. So I need to.
And I guess I included this because when we're seeing people who have these sorts of pathologies in the acute medical take, these are the sorts of things that we want to rule out when we're examining them and interpreting the blood results.
So which one of these not, okay, everybody, not a commonly cited? I'll just say, Rafael, that's not an allowed question. The word not in the title of the question is against MRCP rules.
Really?
Yeah.
Okay. That's fair enough. I mean, I totally, yeah.
Okay.
It's so hard when something has so many things that it can cause that I couldn't,
Yeah, so in your right question,
not enough things that were important that it didn't cause, if that makes sense. So it became a not. Genuinely what happened there.
Okay, anyway, we'll let you off this time. So can you all choose one of these that is not a complication? And we've got 16, 17. Okay, I'll just project it.
Brilliant. Psychosis. And I couldn't find anything up to date about psychiatric issues, but lots of autoimmune diseases are increasingly sort of being linked to psychiatric manifestations. But yeah, psychosis, I guess, is what I was going for there. So it can cause thrombosis because as you lose lots of your proteins, you don't just lose, say, coagulation factors, you also lose things like antithrombin and protein C and protein S, and that's kind of what I carry in the back of my mind when someone who's got nephrotic proteinuria. If you lose the physiological anticoagulants, then you're more likely to develop a clot. And they're particularly depending on the type of nephrotic syndrome you have, like membranous, they're much more likely to have a major clotting event. Infection, you're much more likely to develop any bacterial infection if you've got fluid accumulating where it shouldn't, so be it the skin, the lungs, the abdomen. And if you lose lots of the physiological kind of antibacterial, antimicrobial components of your circulation, things like complement proteins, the CRP we test for is basically a complement protein. And if you start losing these complement proteins, you're less able to respond to things like pneumococcal infection, streptococcal infection. And hyperlipidemia, I would love to get the input from the endocrinologists here, but I think, the up-to-date suggested that this might be a kind of hepatic response to the loss of all these components in the blood, but it's not something I've ever fully understood. The lipid profile of this patient, nothing came up in red or blue. Okay.
No, carry on. I have got no other ideas as to why that might happen.
So I emailed, while prepping these slides, I looked through the notes and I found the patient had the MDT, and I saw that the pathologist was Dr. Simmons. The consultant that had seen the patient in clinic was Dr. Tomlinson. I'm not sure if he's logged in today, so I think he's in clinic. But they've kindly provided all the histology from their MDT for me to really, do my best shot at interpreting, being not a pathologist. So fortunately, they have included the descriptions at the top. So we'll kind of talk through these. We obviously don't have a normal glomerulus in this patient because he has glomerular nephritis. So What we can see from the right-hand side is, or on the left-hand side, is you've got variably sized glomeruli. So this one looks perhaps a bit larger than it should be, then this one looks smaller. They're not very uniform. When you look a bit more closely, the majority of the glomeruli should just be capillary loops. And here we can see that this sort of mesangial core does appear to be somewhat perhaps expanded, taking up a large proportion of the glomerulus. There may perhaps be sort of more deposition of protein where there shouldn't be. So that's been described as mesangial proliferation. Looking at the right-hand side here again, you can see that this is perhaps even an element of scarring that's taking place, and this is described as sort of focal segmental glomerular sclerosis. And this occurs in the sort of setting of kind of a chronic inflammatory insult. And it does look like the capillary tubes are relatively spared, but that the mesangium has somewhat expanded. And here there are far more nuclei than we'd expect to see. So if we compare internally with what looks like a fairly normal number of nuclei within a glomerulus, to the next slide, there does look like there are subjectively far more blue circles. So it's clearly hypercellular, and there's a kind of mesangial response taking place there. Perhaps there are some infiltrating cells as well. And other glomeruli within the kidneys, the Bowens capsule is occupied by this sort of thick proteinaceous mass of cells. And these are what's called the crescents. And when you perturb glomerular function, rather than filtering protein where it should be, which is into the empty spaces of Bowens capsule, what can happen is podocytes, they let go of the actual capillaries, and they, in an attempt to kind of survive, they grab onto the epithelium of Bowens capsule to try and stay there, because we're only born with a certain number of, million podocytes, and they, over the course of our life, drop off into our urine and don't get replaced. And so perhaps as a response to perturbation locally, they do try and grip, but then they lose their ability to, filter proteins, and you end up with these crescents forming. And generally in nephrotic syndrome, I think as there's more scarring, you lose more protein. And another crescent that you can just see here, but this glomerulus has largely fallen off the side of this block. And looking at the immunofluorescence, this is a glomerulus, and this is largely the sort of mesangial component of the glomerulus seems to be lighting up for immunoglobulin A. And this is conventionally that immunoglobulin that we produce in our secretions in the gut in particular, or the I think there's some in sweat as well. There's usually tends to be the mucosal or body barrier immunoglobulin, and there's lots of it in the glomerulus itself. And on the right hand side, you can see that there's just widespread deposition. So whereas this is quite granular in appearance and specific bits of the mesangial cells are coated in this immunoglobulin, there's loads and loads and loads of complement that's just lighting up the entire mesangial apparatus, rather than the basement membrane, say, or the podocytes. And the reason you get the complement binding is whenever there's an conglomeration of immunoglobulin in a region, complement proteins in the blood just immediately pick that up. So they either pick up the fact that immunoglobulin is bound to something, be it a microbe or a cell, or that CRP has bound to the surface of an organism. And then that kicks off the classical pathway, which activates C3 that then coats whatever that substance is that's got immunoglobulin into it. And the aim of that is ultimately to lyse and destroy whatever it is that's been tagged for deletion by the immunoglobulin. Now, immunoglobulin A, I don't think is a commonly sort of potent activator of the complement cascade. And looking at up to date, the pathology of this is really weird. It seems to be that this mucosal immunoglobulin is abnormal in these patients, and the stuff that should be in the gut tends to be instead in the circulation. And you oddly end up mounting an antibody response to this circulating IgA that normally, I guess, wouldn't be in the circulation in such large quantities. And you get, again, this sort of phenomena of immune complexes forming and IgG binding what is IgA where it shouldn't be found normally, and depositing for whatever reason, specifically in the mesangium. So the timeline of the events here, the patient was admitted for 48 hours, had all the tests, and then was sent home for outpatient follow-up. During the admission, we only gave him 40 mg subcut of enoxaparin, and I was just hoping to sort of put it out to the audience as to what you'd do in that situation, whether you'd give just the 40 mg, especially as we're in the COVID era where anybody with COVID who comes in needing oxygen gets being put on 1 mg per kilo twice a day. I feel like these patients perhaps at least from reading, that up to date suggests putting them on the prophylactic dose for these patients should be the normal dose we'd use to treat thrombosis. He wasn't hypoxic and wasn't given any additional furosemide. The renal function improved, and then with no specific intervention, he eventually went home. He was then seen in an outpatient clinic a couple of weeks later, where a plan was made for biopsy. The bloods came back after the clinic was over, and the potassium was 6.5, so the patient was sent back to the ED for retesting and furosemide. Within the ED, the potassium was 5, and it was discussed again with the renal registrar, who advised give nothing and await biopsy. So the patient spent, I guess, until February with no specific management for anything. The biopsy happened in late January. The MDT happened a couple of weeks ago and has now been started on the sartan and aspirin. I don't know actually if Dr. Thompson's or if anybody's got experience with a renal job. Someone suggested instead of enoxaparin, can we just give aspirin? So I guess that's what's ultimately happened.
Although they're very different in what they do.
Yeah.
So I'd like to hear from an expert, really. Joe's an expert.
I'll put my camera on. Yeah, I mean, it sounds as though this man had impaired renal function. I can't really tell. Initially, I thought this was quite likely to perhaps be a vasculitis based on his previous cavitating pneumonia. And I can't really tie in why he was bruising, unless the bruising was just part of the fragility that you get in your skin when your skin starts to expand from swelling. If his renal function, the biopsy to me looked like a fairly stable, non-aggressive form of IgA nephropathy. And IgA nephropathy is one of the commoner causes of nephrotic syndrome. You had a mixture of both, and how you would treat it really depends on the histology and what sort of what the progress of the disease is, because you can get what we call crescentic IgA nephropathy, where you get a lot of crescents and it's very, very aggressive. And you need to treat that usually with, well, I'm not totally up to date on the treatment, but that will need quite heavy immunosuppressive treatment. And then there are more benign indolent forms which present with a degree of renal impairment that's relatively stable, where you would treat the proteinuria with an ARB.
Okay.
And aspirin will prevent a lot of microvascular problems in the glomeruli. All nephrotic syndrome patients tend to be prone to thrombosis, but I think at the moment the guidelines aren't that you need to fully anticoagulate people with nephrotic syndrome. So from what I can see here, looking at the biopsy and looking at how he was treated, they think the IgA nephropathy is a relatively stable thing, and how you would treat it, we'd obviously need to follow him up, usually about once every 6 months. Control the blood pressure very tightly is critically important. Rather like in diabetic nephropathy, any progression of the disease is really tied in with how tightly you manage the blood pressure. So irbesartan as an ARB will bring down the proteinuria and also control the blood pressure, and I suspect they'll be following him up every 3 to 6 months. It can vary during the course. You can go from having a fairly indolent disease to suddenly becoming crescentic. And so, yeah, careful control of the blood pressure and is the mainstay of treatment, providing that the renal function is improving and not getting worse. But how you treat it does depend on the histology and how quickly the decline in renal function happens.
That's awesome.
Yeah.
And the rash, I totally agree. I don't really know where the rash fits in.
Mm-hmm.
He had that funny nodular prurigo, and also he's on a steroid cream. So was he putting a lot of that on?
Yeah.
Steroid.
I see. Yeah, that could also be it.
Yeah.
He wasn't. I don't know how much he was putting on. He did have it. He said he was pointing towards the nodules that were his nodular prurigo. He recognised which ones they were, and he only put the cream over those areas.
Right.
But I guess it could be if steroid cream could
be absorbed. Yeah, he might be on a lot. Any other questions from anybody? That was a great case. Rafael, we got to appoint you as a permanent educator. That was fantastically educational, can I say, and really well explained. And we should do the other case next week and the one after the following week. This is very, very, very useful.
Mhm.
Any questions from anybody about? There's a question there. I don't know, Joe, if you can answer this about the differences between enoxaparin and aspirin for this condition.
I'm not sure I can answer it completely. Obviously, enoxaparin, if you're talking about this patient being managed as an outpatient, and therefore giving subcutaneous enoxaparin as an outpatient is that you're doing it for two different reasons. I think the aspirin as an outpatient thing for trying to reduce microthrombi and for its antiplatelet benefit is there. The risk of thrombosis in an ambulant treated patient in the community is not so great, so you probably wouldn't give, you'd probably give this man, if you know, enoxaparin as you would for any VTE prophylaxis if they came into hospital. Very severely nephrotic people who, you know, albumins of 10 and so are often anticoagulated to prevent one of the major complications of severe nephrotic syndrome, which is a renal vein thrombosis. But the level of proteinuria that he has and the level of albumins of that would be unusual. So I think these are outpatient management things, and you wouldn't need him to inject enoxaparin as an ambulant outpatient.
It's the first time I've seen a patient that has this. Like, it was the first time I came across it basically since fourth year of med school, which is like a long time ago now. And how often do we see more of them now because of COVID, or not so much, just because they didn't get seen before or picked up?
No, I think in general, primary renal, you know, we see people with renal impairment. Actually, primary renal inflammatory conditions are relatively rare presentations on the acute general medical take. But the critical thing here is you can diagnose somebody with a problem with their kidneys very simply in ED by dipsticking the urine. And it's the one thing that we always forget to do. Often we get so down, you know, let's do anchors and ANAs. You know, you have the answer. There's something wrong with this man's kidneys in ED because he's got heavy proteinuria and hematuria. And so I'm always banging on about people testing urine, because I know we've got, you know, we're usually testing to look for urinary infection, but somebody who's hypertensive with renal impairment, you know, your basic investigations get you onto the right path very quickly.
I think Anna said something here that the NICE guidelines say no urine dips over 65, and that's probably because of the use for UTIs.
Yes, and it's not particularly useful for infection. And yes, but in terms of, you know, somebody with an inflammatory process going on, because the vast majority of people that we see within AKI within acute medicine don't have a primary renal pathology. They may have been hypotensive, they may have got, you know, dry. There are all sorts of reasons why you can have an acute kidney injury. But if the acute kidney injury is secondary to a primary renal problem, then the urine dipstick will be abnormal. Yeah.
I think the problem that I guess I as a foundation doctor, and so in this situation, I'll be totally honest, that urine dipstick I presented, I couldn't even find the uploaded results. And I remember actually, I wasn't looking after the patient afterwards, but I remember telling the team who were, just get that urine dip, just, you know, hold the bottle for the patient so that we can collect it. Because I sent off the urines, but somehow there was no dipstick uploaded onto the system. What the data I had was from the GP letter that I remembered.
Yes. And
I didn't have a...
Yeah, it's a simple thing. And, you know, we don't want to be dipping every elderly patient who comes into hospital's urine because, you know, there are positives, but, you know, it's misleading. But in somebody that's specifically presented with renal impairment and hypertension and edema, you need to know whether or not, and if they've got heavy proteinuria, that's on it. You don't need the urine PCRs and all this stuff that comes back a day or two later. If you've got heavy proteinuria, it will be evident on a simple dipstick in the ED. And if you've got hematuria as well, that again is more compelling, that there may be a rapidly progressive glomerulonephritis. Diabetics rarely have hematuria as well. They just generally have with proteinuria, and so that will also point you heavy hematuria. Well, dipstick positive hematuria and heavy proteinuria. There's definitely an inflammatory process going on in the kidney.
Doris got a hand up.
Yeah.
I couldn't agree more. Even as an intensivist and anaesthetist, I really, really, really like the dipsticks, and I could give plenty of anecdotes where it's helped immensely to diagnose an acidosis and lots of other things, not only specific renal things. And I agree also that the documentation is a bit haphazard. I am aware that in some other hospitals, you can just put the dipstick thing into sort of an automatic reader, and that can then be printed out on a little strip, which could be added to paper notes. I sometimes now see it as a POC, a point of care test that the nurses from the ED document, but it's still not consistent. So I think that would be really important, although it's such a simple test, but we should work towards having it better documented in our electronic records.
Yes, thank